Welcome to another MedCram lecture. We're going to talk about some really interesting developments with vitamin C in septic shock. And if you've been following this, you'll know that there is a paper that was published in Chest a while ago by the author of Merrick, who looked at vitamin C and hydrocortisone and thiamine in the treatment of septic shock that was vasopressor dependent. Basically what he did real quickly is he looked at 47 patients before they initiated the protocol and then 47 patients after he initiated the protocol. And the results were that the mortality rate before they initiated the protocol was 40.4% mortality, and afterwards it dropped to a whopping 8.5% mortality. So statistically significant, though not a randomized placebo-controlled trial. And so this really put vitamin C on the map for septic shock. And of course, he got a lot of criticism because people started to use vitamin C in septic shock, and there really wasn't a randomized placebo-controlled trial. However, his point was that there really isn't a lot of risk in using vitamin C. And so this war between should we use it, should we not use it, has been going back and forth for some period of time. In the meantime, there is a randomized placebo-controlled trial, which we'll talk about coming up, called Victus, which is looking at a multi-centered study. However, something really interesting has come up recently regarding this topic. And that thing is an unlikely publication called the Citrus ALI or ALI trial that was published in JAMA. And this will be in the link below. That really has raised some eyebrows here in terms of vitamin C, because this is a randomized placebo-controlled trial. In fact, the N here was not 47 and 47, but rather 167 patients. It was a multi-centered trial. And again, it was a randomized placebo-controlled trial. So what happened here? Well, patients were enrolled that were in septic shock, but they were not started on vitamin C until they were within 48 hours of ARDS. And that was defined as a PF ratio of less than 300. So they didn't get vitamin C in septic shock. They had to wait until they were in ARDS. And that'll become clear as to why that was in the trial in just a little bit. The other distinction was instead of getting the traditional Merrick protocol of 1,500 milligrams of vitamin C Q6 hours, they actually got just 50 milligrams. I say just because they did not get hydrocortisone and they did not get thiamine. They just got 50 milligrams per kilogram of vitamin C IV. So if you think about a typical 70 kilogram man, that would be 3,500 milligrams every 6 hours, which was about 3 times the dose that Merrick's study got that was published in Chest. Okay, and they looked at a number of endpoints, and here is where the problem is. So there are secondary endpoints and there's primary endpoints, and the study was powered to look at the primary endpoints. So what were the primary endpoints? The first primary endpoint was the change in SOFA score. That's a score that looks at the severity of illness. The other thing that I looked at was CRP, and finally another compound called thrombomodulin. Now, in terms of secondary endpoints, well, there was about 46 secondary endpoints. And the reason why there were so many endpoints is that's typically what people do when they have studies like this, because they want to generate more hypotheses to see what else could be abnormal. So you really can't draw conclusions from secondary endpoints. You can only really draw conclusions from primary endpoints because usually there's so many secondary endpoints that you're going to look at that if you look at 50 different endpoints, and in this case there was 46 of them, 1 or 2 of them are bound to become statistically significant just because you're looking at so many of them. Well, as it turns out, one of their secondary endpoints, and here's where the problem was, is mortality. And you're like, mortality? Shouldn't that be a primary endpoint? Well, here's the problem. This study was funded by the NIH. And I got to give you a little bit of background. This was really not a septic shock study. This was an ARD study. And this is what happened. The NIH was wanting to fund studies for ARDS. And the problem is that there's only 3 things that has been shown to improve survival in ARDS. And you can go ahead and look at medcram.com for lectures on what those three things are. But briefly, they are prone positioning, low tidal volume, and paralysis in patients with PF ratios of less than 150. And so the NIH took a little different standpoint. They said, you know what, we're willing to fund studies. Since we're having such a hard time finding mortality benefits in studies, let's go for hypothesis-generating studies, and let's look for some smaller things. Let's look for SOFA score. Let's look for some intermediate markers. Let's look for some surrogates. And so that's why the authors decided to look for change in SOFA, CRP, and thrombomodulin. This is also the reason why they decided to look at ARDS instead of just sepsis. So in other words, what they did is, we'll take the septic shock patients, but we'll wait for them to be in ARDS before we start the high-dose vitamin C. So because of the way the funding was given and because of the preconditions for funding, that's what made the study kind of awkward in that they waited for ARDS before starting it instead of starting it way back here at septic shock. And it's kind of the reason why we have the flip-flop. Well, here are the results. When they looked at the primary outcome for the primary endpoints, there was no statistical significant benefit whatsoever. There was no change in SOFA scores, no change in CRP, no change in thrombomodulin between those that got vitamin C and those that got placebo. However, and sit down for this, there was a huge secondary mortality benefit for those that were on vitamin C. Well, I shouldn't say huge. There was a difference. In those that got the vitamin C arm, the mortality was 29.8%, greater than the 8% that we saw in Merrick's protocol study. But remember, this was started a way later than septic shock showed up in. The other thing that they saw was the mortality in the placebo. So this is the vitamin C group, and in the placebo group, the mortality was 46.3%. And this was statistically significant of a p-value of 0.01. So not borderline, but pretty specific. So what do you do now? What do you do when you have a primary endpoint that shows no change, and yet through some mechanism that is unknown, we have a mortality benefit? This was a 28-day mortality benefit in those that were on vitamin C. And it gets even better than that, because if you look at the actual graph of survival, or indeed mortality, the placebo, the mortality rose very quickly at the beginning. So this is placebo, but the vitamin C group did not. And then after it was stopped, it then reached and plateaued off. And so during this period of time when vitamin C was being infused, there was this pretty sizable difference between those that were not getting the vitamin C and those that were getting the vitamin C during that period of time. And so this, of course, has raised a firestorm, and people are debating, because here we have a randomized placebo-controlled trial that shows a mortality benefit. But because the study was not powered to look at mortality, because it was a secondary endpoint, and we did not correct for these multiple secondary endpoints, mortality falls out. And so why would it be then that the primary endpoints were not statistically significant? Well, one of the explanations that have been tossed around, and I'll include a link to a really nice website that goes through this, is that it's possible that the vitamin C group was benefited so much that because less people died, more people with bad SOFA scores or less improving SOFA scores were included in the analysis, whereas those that were on the placebo, those patients died, the worst ones, and that made the SOFA scores in that group look better because the worst ones were eliminated, or the worst ones that were not improving the best were eliminated. And that's why there might have been no statistical significance. So take a look at those links. It's a new update. I think it's very fascinating. But as I mentioned in the middle of this is Victus should be coming out in the next few months. So if you want some more information about how to treat septic shock and ARDS, please join us at medcram.com for all the latest and online instructional videos. Thanks for joining us.